today's session is very, very impactful. We're joined today by Dr. Charan Aaditya Reddy from Gandhi Medical College, Secunderabad, and he is bringing us a very compelling real life case of spinal cord injury with polytrauma. And this is not just going to be a normal clinical discussion, it's going to be a journey through complexity, decision making, and multidisciplinary care. And you're going to be seeing orthopedics, trauma surgery, general surgery, and neurosurgery intersect in one story.
Yeah, a very good evening, everyone. I'm Dr. Charan Aaditya Reddy from the batch of 2K19 from Gandhi Medical College. And I'll be presenting a complex and interesting case of a spinal cord injury. And yeah, this is my own case. And it is going to be interesting and, helpful for you all. Coming to the introduction, this is a case of a 21-year-old male patient, that is me, a resident of Hyderabad. It is a case of polytrauma due to road traffic accident, like basically four-wheeler versus divider collision. Coming to the chief complaints, the patient was brought to the emergency department in unconscious state, unable to talk or move his limbs, with a history of left ear bleed. There was severe blood loss due to multiple open soft tissue injuries all over the body, and it was chaotic actually. And I sustained injuries to my head, chest, abdomen, right arm, and both my lower limbs. And advanced trauma and life support protocol was followed, which includes three components. That is primary survey, resuscitation, and secondary survey. Like everything is fine, right? I'll be continuing the video and my audio.
Yeah, it's good. It's good.
Done, sure. Thank you. So yeah, our ATLS protocol involves three components. That is primary survey, resuscitation, and secondary survey. And then under primary survey, we'll be having the first component, that is breathing and ventilation, where the chest movements were checked and they were reduced on the right side. SpO2 was not recordable. Chest compression couldn't be assessed, and there were no visible chest injuries. Like as a part of cervical spine immobilization, it is maintained using a cervical collar, and then the patient was intubated and was placed on invasive mechanical ventilation. And under circulation and hemorrhage control, they had to follow the massive blood transfusion protocol. And at presentation, I was in grade 4 shock, which was like a severe shock. Like there was major external bleeding present, and like the blood pressure and pulse rate were not recordable because they were very low. And I was resuscitated with 6 units of random donor platelet, 6 units of fresh frozen plasma, and 3 units of packed RBC. As a part of neurological status examination, my Glasgow Coma Scale score was 3, that is E1, V1, and M1. Motor and sensory functions couldn't be assessed. And as a part of differential diagnosis, they were suspecting traumatic brain injury and spinal cord injury. And under secondary survey, like there will be detailed head and toe examination where they could they could find like lacerations all over the body on my left knee, right thigh, right upper limb, and left upper limb. Coming to the investigations part, X-rays showed right hemothorax with the pulmonary contusion, a mandibular fracture, shaft of femur fracture, and shaft of humerus fracture. And NCCT brain showed diffuse cerebral edema, whereas the CT didn't show any fractures as in. And then EFAST, which is ultrasound, was done, which showed fluid in the hepatorenal pouch. Every department in the hospital was touched almost, like neurosurgery for head and spinal injuries, orthopedics for fractures, and general and trauma surgery for like abdominal injuries and other injuries. And as a part of management, I was taken up for frontoparieto-temporal decompressive craniotomy, and the bone flap was removed and it was kept in the right subumbilical region subcutaneously inside me. And then on the same day, lavage of right and left knees were done with external fixation placement in my right femur. And then I was shifted to critical care unit on with improvement in my GCS score. I was then extubated on day 7 of hospital stay. And post extubation, neurological examinations showed, with the GCS of E4, V4, M5, but I couldn't move my limbs, lower body actually. So then MRI spine was done, which unfortunately showed a ligamentous chance fracture in my spine with cord discontinuity over D3, D4, D5, and D6. And then on and then I underwent my spine posterior instrumentation of the spine, like to stabilize my spine because there was a chance fracture. and then close reduction and nailing femur surgery of my right femur was done, and then open reduction and internal fixation of my humerus was done. And then after 10 days of so many procedures and interventions, I was then discharged following rehabilitation advice. Like while I was discharged, I was hemodynamically stable. GCS was E4, B5, M6. Like there was severe surgical site pain. There was intermittent irrelevant speech as well. And then you can call it ICU delirium. And then I was able to take oral feeds and a case of paraplegia. And coming to the case discussion, what is spinal cord injury? It is damage to the spinal cord that results in loss of functions such as mobility and sensation. Like it can be either due to a traumatic cause or a non-traumatic cause like tumors, infection, and some degenerative diseases. It can be classified into, it can be either complete spinal cord injury or incomplete spinal cord injury. Mine was a complete transection of the spinal cord at thoracic level 3. There is total loss of motor and sensory function in this case. In case of incomplete spinal cord injury, there can be some remaining like modalities. Matlab, you can have some sensory and motor functions below the injury site. It is not complete. There will be some sparing of sensations. And immediately after the injury, the patient lands up in a condition called spinal shock, which can be divided into 4 stages. Stage 1 is areflexia, and stage 2 is initial return of reflexes. Stage 3 is early hyperreflexia, and stage 4 is spasticity. And then coming to the management of spinal cord injury, rehabilitation programs like physiotherapy, occupational therapy, and wheelchair mobility training is the key. It like helps a lot in long-term management of the case. And as this is a very severe, when this has got a very severe impact mentally on the patient, psychological support and family counseling is advised. And thank God, like, and I'm very proud that I didn't need any psychological support as in. So yeah, I'm proud of that. And then coming to this, like you should be taken care of by bedsore prevention and DVT prevention. And many new technological approaches have come recently. One is stem cell therapy, and the other is this is still in trials actually. Epidural stimulation helped in case of incomplete spinal cord injury. There are many exoskeletons and robotics to improve the lifestyle. And there is this technology called Neuralink by Elon Musk, where you'll be placed like matlab, a chip will be placed inside the brain, and you can control like a digital device using thoughts. You don't have to like do anything. The chip will be like collecting information from the brain, and that will be transmitting the information to the external device, and you can control that device with just your thoughts. And yeah, I think like yeah, this is all like about the case presentation. And now like everyone grab a pen and paper. Let's let's discuss about all the PYQs and very high yield stuff related to this case. It'll be really helpful for your NEET PG and INI-CET preparation, hopefully. Can I like start? Can I like go forward? Dr. Varshini, am I audible?
Yeah, you can go ahead.
Sure, sure. Yeah. I'll be starting with the high yield, like it'll take 10 to 15 minutes, I guess. Let us now like everyone grab a pen and paper. Let us now discuss about the high yield stuff and exam oriented points in this case scenario, actually. So, yeah, coming to yeah, so in chief complaints, I mentioned about the left ear bleed, right? So, what are all the causes of left ear bleed? One can be external auditory canal trauma, one can be tympanic membrane perforation. One can be fracture of base of skull. Yeah, these are all the differential. You can also expect CSF otorrhea, where like there is a mix of blood with CSF as well. Like in exam, I mean, ear bleed is not really important. You can expect questions on nose bleed actually, so which is known as epistaxis. So yeah, so for us to talk about epistaxis, we should be first knowing about the blood supply of the nose. So blood supply of the nose is by internal carotid artery as well as external carotid artery. From internal carotid artery, you'll be having anterior ethmoidal artery as well as posterior ethmoidal artery. This is really important for every exam for INI-CET as well as NEET PG. From external carotid artery, you'll be having maxillary artery, and the other is facial artery. And from maxillary artery, we'll be having two branches. One is spinopalatine artery, and the other is greater palatine artery. From facial artery, there is superior labial artery. So this is all about the arterial supply of the nose. And yeah, anatomically, like we talk about Little's area, which is like the most common site for epistaxis. Location is the anterior-inferior part of the nasal septum actually, and there is the location of Kieselbach's plexus, which is the site for epistaxis. And he'll be asking us about the components, what are all the arteries involved in the formation of Kieselbach's plexus. So posterior ethmoidal artery is not involved in that. There is anterior ethmoidal artery, sphenopalatine artery, greater palatine artery, and superior labial artery. And the most common artery involved in epistaxis is the sphenopalatine artery. That is a very important question. And then coming to the management of nosebleed, I'll be giving you a flow chart. The first procedure is you'll be doing a Hippocratic or Trotter's method, where you'll be asking where the patient is asked to bend forward and pinch his nose. If there's no, the bleeding continues, cauterization is done. If the bleeding still continues, anterior nasal packing is done, followed by posterior nasal packing. And the final terminal intervention will be ligation of the arteries. And here, like the important question we should be talking about is no matter what, no matter even if the bleeding doesn't stop, internal carotid artery is never ligated because this will be life threatening to the patient. So internal carotid artery shouldn't be ligated at any cost. And then, yeah, ATLS protocol was followed under primary survey. Like, so yeah, airway management and cervical protection is the key in management actually. So in this airway management, you will be asked about the triple maneuver. You're able to see my annotation, right? I'm using a digital pencil to write on the screen. That is visible, right?
Yes, yes, everything is visible.
Sure. So like you'll be doing triple maneuver. This is a really important question from anesthesia in both NEET PG and INI-CET, where they'll be giving you a diagram and asking you what is happening in the diagram. So triple maneuver includes three components. That is head tilt, and then chin lift, and then the jaw thrust maneuver. So this is done to protect the airway, and this prevents the tongue fall back. And then transport of the patient is also really important, where you'll be transporting the patient in two positions are allowed. One is supine position and the other is prone position. In case of prone position, you can prevent aspiration in the patient actually. And what is not advised is lateral position is not advised. Actually, you can't shift the patient in lateral position because cervical immobilization is not possible in lateral position. This is a big no. And then we'll be asked questions about the triage, which is usually done in mass casualties, where patients will be labeled colors based on the severity of their condition. So we'll be having four colors actually. One is red, the other is yellow, green, and then is black. 1 second, yeah. So red patients are like critical patients where they should be given first priority. Like a treatment should be started within 1 hour because risk of mortality is very high in them. In case of yellow, you can 4 to 6 hours time you'll be having for you to attend the case. And in case of green, they are like mobile and like they sustain like minor fractures and all. And black is like dead patients. So triage is really helpful in like mass casualties and accidents. Actually, this is a really important question again. And then coming to the airway management, first will be then, yeah, 1 second, yeah. First and gold standard will be endotracheal intubation. So if this thing fails, you'll be having two methods. As an emergency method, you'll be doing needle cricothyroidotomy, And as the definitive management, you'll be doing tracheostomy. So if endotracheal intubation fails, you'll be having these two options actually. And then comes circulation and hemorrhage control. This is really important. Like I already told you, massive blood transfusion protocol was followed in me. So what is when do you call something as a massive blood transfusion protocol? So if there is complete, blood in like when total complete blood of the patient is like involved in less than 24 hours, you can call it as a massive blood transfusion protocol. And also when you give less than, when you give 4 units of blood, more than 4 units of blood in less than 1 hour, you can still call it as a massive blood transfusion protocol. And he'll be asking you also about the complications of massive blood transfusion protocol. Yeah, this is important. So you can remember this using the mnemonic catch. Yeah, so one is citrate toxicity because blood will be stored in citrate. Citrate is present in the blood banks. So you'll be experiencing citrate toxicity if you perform massive blood transfusion protocol. There can be acidosis or alkalosis. There can be hypothermia as well. There can be coagulation disorders. And then we can also expect hyperkalemia, which is really bad, which can cause cardiac arrhythmias in the patient. So these are all the complications of citrate toxicity. You can remember this using the mnemonic catch. And the other thing is the same mnemonic is also used in an immunodeficiency disorder, that is DiGeorge syndrome, where the mnemonic is catch 22 because chromosome 22 is involved in case of DiGeorge syndrome. And coming to the disability and neurological examination, like this is very favorite question of the examiner, that is the GCS score. It has got three components. One is eye movements, the other is verbal response, and the other is motor response. It is given points like 4. This is given 5 points maximum, and this is given 6 points. So like you'll be calculating GCS score of the patient immediately in the year, and then yeah, and if the score is 12 to 15, it is a minor head injury. If it is 8 to 12, it is moderate head injury, and if it's less than 8, you can call it a severe head injury. And my score was 3, that is E1, V1, M1 on presentation. And then yeah, INI-CET is most favorite question. Like you can expect this question in every single shift actually. So let's talk about traumatic brain injury now. So what is traumatic brain injury? That happens due to shearing force in between the gray and white matter junction inside the brain. That is due to rapid acceleration or deceleration motor vehicle accidents. And yeah, this has got worst prognosis. When do you suspect traumatic brain injury in a patient? Like when there's no improvement in like the GCS score of the patient, no matter what, you can suspect a traumatic brain injury. And then yeah, CT, the worst part is CT can't detect any abnormality. If the case is traumatic brain injury, CT will be absolutely normal. And investigation of choice will be susceptibility weighted MRI. This is the investigation of choice, and where you can see petechial hemorrhages in the gray and white matter junction. This has got the worst prognosis, and luck, thank God, this is not my case. I couldn't be, I wouldn't be sitting in front of you all presenting my case if it's a traumatic brain injury, actually. So, yeah, coming to the secondary survey, there were lacerations all over the body. This reminds me of a really important topic from forensic medicine FMT, that is mechanical injuries caused by different weapons. Actually, you can classify this into if the weapon is sharp or, yeah, one second. Yeah, you can classify it as if the weapon is sharp weapon, if it is blunt trauma, or if it is a stab wound. Yeah. Under sharp, if the weapon is, under sharp objects, you can classify further into incision, And blunt includes abrasion. 2 is contusion, and the other is laceration. And if the object is a pointed object, it is a stab wound. And under you can also have a chop wound in this. So if the object is a big object like axe or something, you can expect chop wound. If it is like a clean, sharp knife or something, there will be incision. Abrasion is a superficial damage to the epidermis. It is partial damage. Contusion is like accumulation of blood in the dermis under the epidermis, and laceration is diffuse like bad irregular margin injury actually. And then like I already told you, stab wound is when it is because of some pointed object. The highest dimension will be the depth of the injury. This is important. They'll be asking this. Like depth is more in this case. And also we can expect like they'll I mean you should be knowing about the difference between incision and laceration. So incision is a clean, matlab, the boundaries are very clean in case of an incision, but if it's laceration, it has got dirty boundaries. And then the base of the wound is damaged in case of laceration. And then uh, and then blood loss is more in case of incision compared to laceration. And then yeah, that's all. That is all about incision and laceration. So the like hair bulb and the vessels are crushed in case of laceration, that we can say. And coming to the investigations, like X-rays showed hemothorax and pulmonary contusion. 1 second. Eventually, audio na. అది నీకు మూల తక్కువ ఉంది. Okay, I'll this. I can't wait. Hello, can you hear me?
Yes, yes, you're perfectly audible.
Sure, sure. So now talking about the chest X-ray presentation, that even that is important for like PG entrance point of view. Like we can, yeah, one is hemothorax, the other is pleural effusion, and the other is pneumothorax. Pneumothorax can be further classified into simple pneumothorax or tension pneumothorax, depending on how the patient is presenting. If the patient is stable, you can call it simple pneumothorax. And if the patient is not, if the vitals are unstable, then that is a case of tension pneumothorax. There is collapse of the lung, affected lung, and there is contralateral shift of the trachea. There is tracheal deviation present in this case. And pleural effusion, like as we all know, it is due to accumulation of fluid in the pleural cavity. And hemothorax is because of accumulation of blood in the pleural cavity. And hemothorax, coming to the management of hemothorax, like as a part of emergency management, needle thoracocentesis is done, and as a part of definitive management, chest tube insertion is done. Yeah, and like coming to anatomy, where is this needle placed? In case of adults, it is fifth intercostal space, mid axillary line, and if it's children, it is second intercostal space, mid clavicular line. And like where is it placed? Is it if we take these two ribs, you'll be having neurovascular structures in the lower border of the rib. Okay, this will be the neurovascular structures. So needle is usually placed in the upper border of lower rib. So this will be the position of needle in case of needle thoracocentesis. Will be also asked about like local anesthesia, needle placement. So if you're planning to give local anesthesia, the needle is placed here in the lower border of the upper lip because like the nerve should be anesthetized, right? So in case of anesthesia, in case of like local anesthesia, the needle is placed in the lower border of upper rib. And in case of needle thoracocentesis, it is usually placed in the upper border of lower rib. This is really important. And then, yeah, will you be checking if, and yeah, coming to the definitive management, chest tube insertion is done. And that is, 1 second. So chest tube is, I mean, where is the chest tube placed? That is an important question. That is usually placed in the triangle of safety. So coming to the borders of triangle of safety, apex is formed by the axilla. Anterior border is formed by the anterior axillary line. Posterior border is formed by the mid-axillary line, and the lower border is formed by the fifth intercostal space, actually. So this is the location for the placement of chest tube in case of definitive management of the hemothorax. And then how will you be checking if the chest tube is working? I mean, you'll be like checking the movement of fluid in the like chest tube system, actually. Movement of fluid indicates if the chest tube system is working or not. And yeah, like consultations and all, like management, we already discussed that it's not really important for NEET PG and INI-CET point of view. Mm, mm, mm. Yeah, I think, yeah, this is all about the case presentation, PYQ discussion and high yield points. And yeah, you can see me actually, don't be scared, sorry. So this was me after the injury in the hospital, and this was me 1 month after the injury, chilling in the hospital actually. So yeah, there is a good news I want to share with you all. So I'll be joining my post-graduation course in MD radiology at ESI Hospital Hyderabad soon in 1 week time. And I think my radiology journey has begun long ago, like as a patient, from being imaged to now as a doctor, like studying and interpreting images, and like I'm like really happy. And these are all MRI images of my case. You can see cord damage here. 1 second. You can see spinal, I mean, damage to the cord here. Like there is transection of the spinal cord in these places. And then coming to like my femur, it is a long story. What happened initially was there was a shaft of femur fracture. So internal fixation intramedullary device was placed. And then unfortunately, it got infected with a very deadly bacteria that is Klebsiella. So like yeah, it was osteomyelitis of the bone actually, and I had to take 6 weeks of antibiotics and all. And they removed this device and placed external fixation because internal fixation is contraindicated in case of osteomyelitis or any infection of the bone. And after 6 months of external fixation, they removed. I mean, after knowing the bone is good, so they had to remove the external fixation, and unfortunately, the bone got fractured again. And then as a last resort, they placed internal fixation with screws and nails again. You can see like all the surgical site pictures here. This was the like external fixation. This one as well. And then coming to chest X-rays. Here you can see spinal cord screws which was placed to stabilize the spine as there was a chance fracture of the spine. And then these were my X-rays. You can see complete collapse of this lung with severe hemothorax, and then you can see some signs of pneumothorax this side. You can see signs of pneumothorax this side as well. There is like blackening of the lung on this side, and after chest physiotherapy and like antibiotics, there was some improvement in the hemothorax. Actually, there is some improvement here. You can see. And then coming to the last part, like there is humerus, there was also shaft of humerus fractures in my case. So they had to place an implant in my humerus as well. Even humerus is a really important question for NEET PG and both NEET PG and INI-CET. So they'll be asking about proximal fracture of the humerus, shaft of humerus shaft fracture, and supracondylar fracture of the humerus. Coming to the proximal humerus fracture, there is a named classification called Neer's classification. This is important. And then most common nerve injured here is axillary nerve. Coming to the shaft of humerus fracture, the most common nerve overall in humerus fractures is the radial nerve that is usually seen in the shaft of humerus fractures. Even my radial nerve was injured, unfortunately. And they'll also be asking you about the device, like what will you be doing if it's I mean, if radial nerve is injured, there is cock-up splint actually, dynamic cock-up splint, which is usually used in case of radial nerve injury. And coming to the supracondylar fracture, this is like the most common fracture overall in case of children. They'll be mentioning in the clinical vignette that someone has like fallen like with his arm outstretched, and then comes most common nerve injured here will be anterior interosseous nerve, which is internal branch of median nerve, and most common artery involved will be brachial artery, which is the part of cubital fossa. We'll be having a mnemonic MBBR, the components of cubital fossa. Even this is important. And yeah, this is all about the case presentation and PYQ discussion. And I don't know if I should crack jokes on this, but I right now have 6 to 8 kgs of metallic implants in my body, and I think I can call myself Iron Man. And yeah, these are all photos after the accident. Actually, I'm like super proud of how I handled this scenario. And yeah, all I want to say is no matter what you're going through and everything and all, setbacks are always temporary, whereas comebacks are permanent. Yeah, yeah. Thank you so much, actually. Like, if this case helped you learn something, like, clinically, or, it gave you a small push to keep going, like, I'll be more than happy. Thank you so much, everyone. And like, yeah, like, I'm happy to help you all. Matlab, if there's anything, you can actually reach out. Like I mentioned my Instagram handle and my contact here. And yeah, this is not a paid promotion. Like I thank Maro for like being my teacher since day one of my MBBS until me joining my residency program. It was really helpful for me, and I suggest you all to be using. Matlab, Maro is a really great platform for you all for like learning actually, both for NEET PG, INI-CET, and also for your MBBS prof exams. So yeah, thank you so much, and that's all from my side.
Hey guys, it was such an amazing session. I have really learned a lot of things from this session. It was really inspirational. A heartfelt
Thank you
thank you
so
to
much.
Charan Aditya Reddy from Gandhi Medical College, Sikandrabad, for presenting such a challenging case that actually he has run through. An amazing case of spinal cord injuries is polytrauma, handled with clarity, honesty, and strong clinical insight. Actually, it was such an amazing experience that he has actually analyzed each and every X-ray of him personally. The way he highlighted this case in a multidisciplinary thinking and real world decision making is truly stand out.